My name is Stephen Cohen. I'm the Edmund I. Eager Chair of Anesthesiology at Northwestern University and a professor of anesthesiology, physical medicine and rehabilitation, neurology, psychiatry, and neurological surgery. And I hold similar appointments at Walter Reed National Military Medical Center. The title of my talk today is Ketamine for Pain, a review of current evidence. These are my financial disclosures. These are the objectives. By the end of the talk, you should be able to understand the results and limitations of clinical trials evaluating ketamine for chronic pain and psychiatric conditions, understand the evidence supporting the preemptive use of ketamine in the perioperative setting, be familiar with the limitations of using placebos in ketamine trials and the placebo effect on study outcomes, and be able to weigh the risks and benefits of treating psychiatric conditions with ketamine. So the primary mechanism of action for ketamine is NMDA receptor antagonism, but ketamine also has effects on non-NMDA glutamate receptors, including the upregulation of AMPA and metabotropic glutamate receptors. It's considered a dirty drug. It has effects at many different receptors. It antagonizes nicotinic and muscarinic cholinergic receptors. It can block sodium and potassium channels such that it can be administered intrathecally and one can get spinal analgesia, albeit it's patchy. It interacts with various opioid receptors. It activates D2 dopamine receptors, which are involved in negative reinforcement and reward, locomotion, memory, cognition. It activates L-type voltage-gated calcium channels, which can be involved in pain. It facilitates GABA signaling. GABA is the primary inhibitory neurotransmitter in the central nervous system, and it enhances other descending modulatory pathways. So pain is more than sensation. First described by Melzack, he of Melzack and Wall gate control theory of pain, along with Casey. They described three different pain components: the sensory discriminative component, which is based on nociceptive input and includes magnitude and location of pain. This is probably best measured with quantitative sensory testing. There's also an affective motivational component of pain, which deals with evolutionary arousal, negative emotions, sometimes measured as unpleasantness in clinical trials. And these involve the limbic and reticular structures, older structures. And then there's a cognitive evaluative component, which provides contextual information based on past experiences and likely outcomes. So attitudes, belief, expectations, these are important. These are processed via higher CNS structures. And if you look at, let's say, cancer pain, the FDA has repeatedly said there's no pathophysiological differences between cancer and non-cancer pain. So there's not any unique or singular spinal pathways that transmit each of those. There's no distinct neurotransmitters. What really separates them is that for cancer pain, there's very, very strong affective, motivational, and cognitive evaluative components. People are fearful, they're anxious, they've heard or they've read things about cancer, and they're very concerned. So I will go over this later, but most studies have reported negative effects of ketamine on quantitative sensory testing, which measures the sensory discriminative component after ketamine is out of the body. Ketamine is a short-acting drug. It's out of the body after 2 days. There's very little after 1 day. And in one randomized trial that I'll go over later by Schwartzman, they evaluated the sensory discriminative and the affective motivational components, and they found about a 50% greater reduction in the affective component of pain in patients with complex regional pain syndrome. So there's been a few studies on this. Zhao, back in 2018, did a single low-dose ketamine study and found that it reduced the aversive component of noxious stimuli and that outlasts the anti-nociceptive effects. They also found that the anti-aversive effects were mediated by prolonged suppression of hyperactivity in the anterior cingulate cortex, which regulates pain affect. The rostral ACC is also involved in the placebo response. They found a dose-response relationship, and this could be blocked by rapamycin, an mTORC1 inhibitor, when it was injected into the anterior cingulate cortex. So I could put up 5 slides that are very similar to this. These are animal models. Almost all of them are positive. They've looked at pain in a whole bunch of different models. There are many different models for each type of pain, for inflammatory pain, neuropathic pain. Ketamine is mostly studied for neuropathic pain in animals. So there's way over 100 of these. The generalizable conditions that they've been studied for include all pain categories: neuropathic, nociplastic pain, and nociceptive pain. And the specific generalizable conditions include complex regional pain syndrome, fibromyalgia, cancer, acute inflammatory surgical pain, central pain syndromes, diabetic neuropathy, radiculopathy, visceral pain, which is a form of nociceptive pain, plexopathy, which could involve deafferentation and neuropathic components, inflammatory and degenerative arthritis, all sorts of noxious injuries, including chemical and thermal, central sensitization, and opioid-induced hyperalgesia or intolerance, postherpetic neuralgia. The problem is that animal models translate poorly to people. So generally, investigators measure nociceptive behaviors like paw withdrawal, paw latency, rearing, jumping, things like this. They're believed to be associated with nociception, but we're actually not measuring pain, affective components of pain in particular. And for psychiatric conditions, you have very similar limitations to the models. So ketamine for pain really took off in 2009. So the same issue in the same volume of the journal Pain. There were 2 studies published at the same time. One was by Sigtemans. This was randomized, double-blind, placebo-controlled trial in 60 patients with CRPS type 1. They admitted patients for 100 hours or 4.2 days. They started at very low doses, 5 milligrams per hour or 1.2 mics per kilo per minute, and they increased to 7.2 mics per kilo per minute, which translates to about 30 milligrams per hour in a normal-sized adult. And they found marked decreases in pain compared to placebo. So 7.2 at baseline to 2.7 in week 1, and then it started to gradually creep up. So by week 12, the difference between the treatment and the control group was no longer statistically significant. Secondary outcomes, including function, improved with ketamine, but they were not different than placebo. But here's the thing: 28 out of 30 people who received ketamine correctly guessed that they received ketamine. And there was a very, very high incidence of nausea, vomiting, and psychomimetic effects. Almost everyone. They did not give preemptive medications that might reduce those effects, like a benzodiazepine and an alpha-2 agonist like clonidine. Again, in the same issue, Schwartzman, a neurologist in Pennsylvania, performed another randomized double-blind placebo-controlled trial in 19 patients with CRPS type 1 or 2. And probably a lot of these people had CRPS not otherwise specified. So these patients underwent 10-day infusions, 4 hours per day. So 2 weeks separated by a weekend. They started at 50 milligrams over 4 hours, and they increased to 100 milligrams by the 3rd day. But the trial was stopped early so the dose could be increased. And they reported very modest decreases in pain, 7.7 to 6.1 in the treatment group versus almost no reduction in pain in the placebo group, 7.6. And again, the numbers started to creep up, and after 3 weeks, the difference between groups was not significant. They didn't test the effectiveness of blinding, but as you can see here, there was almost no change in pain in the placebo group, which suggests that probably similar to the Sigderman's trial, blinding was not effective. These were neurologists. They measured quantitative sensory testing, and they found no difference in the ketamine group. There was also no significant improvement in quality of life. They measured serum levels. They found no dose response. 44% of ketamine versus 20% of the saline patients reported dysphoria, fatigue, nausea, vomiting, but they didn't have psychomimetic effects. And these patients were all given midazolam and clonidine to prevent some of those effects. So in a study published about 5 years ago in anesthesiology, Pickering did a randomized double-blind placebo-controlled crossover trial in 20 patients with neuropathic pain. This was published in anesthesiology. So these people had mostly post-surgical neuropathic pain and radiculopathy, so things that anesthesiologists would be interested in. They compared ketamine 0.5 milligrams per kilogram over 2 hours and placebo to ketamine and magnesium, which forms a block over the NMDA receptor that has to be removed before it can be stimulated. And they also had a placebo group. Crossover was at 35 days, and there was no difference at the 35-day primary endpoint, nor were there differences at 2 weeks or after 2 weeks. There was a slight difference favoring ketamine at day 7, but there was no difference compared to the ketamine magnesium, which was also a treatment group. And some might suggest that should have been a more effective treatment group. 10 and 5 ketamine patients improved at 7 and 35 days versus 4 and 3 in the placebo group. And again, they found no differences in secondary outcome measures like quality of life, mood, or sleep. But of course, the study was not powered to detect these differences. Not everyone with chronic pain has a mood disorder or a sleep disorder. So fibromyalgia is considered to be the prototype nociplastic condition, a manifestation of central sensitization. And because ketamine is sometimes said to possibly reboot the nervous system or wind up, this is often considered to be a prime candidate for study. So in 2011, NAPRS took 24 patients with fibromyalgia, randomized them to get relatively low doses of ketamine, 0.5 milligrams per kilogram. That's a typical psychiatric dose versus active placebo, and they got up to 5 milligrams of midazolam. So ketamine reduced spontaneous pain scores through 3 hours, but not afterwards and not through 8-week follow-up. They measured some components of quantitative sensory testing and quality of life through the fibromyalgia impact questionnaire, and they didn't find any differences. They had modest side effects. They were more common in the ketamine group. And again, almost everyone who received midazolam, 11 out of 12 patients, correctly guessed that they did not get ketamine. So cancer pain. Cancer pain is a mixed phenotype pain disorder. Often consists of it consists of nociceptive pain, but often neuropathic pain. Probably more than 1/3 of patients with stage 4 cancer, and often nociplastic pain. So Salus did a study in 20 patients with cancer pain. They were randomized to IV morphine or ketamine infusions, varying from 0.5 to 1 milligram per kilogram per day for 2 days, plus morphine. They increased the ketamine dose for persistent pain. The morphine dose was not standardized. So this was not a great study because people could keep taking morphine until their pain was at a tolerable level. And not surprisingly, they didn't find any difference in pain scores through 48-hour follow-up. This is a systematic review that we did. It was the cover of Anesthesia and Analgesia in July 2019. Wire Arhuru is the first author, and this looked at 7 randomized controlled trials evaluating ketamine for chronic pain conditions. And the first forest plot at the top shows the effects of ketamine on maximum reduction in pain at any time point after 48 hours. So by this time, ketamine is out of your system, and you can see it's a pretty strong effect. When we looked at ketamine versus placebo at the end of 2 weeks, you still see a strong effect. But when you looked at the end of 4 weeks, and again, not every study measured pain scores, at each of these follow-ups, the effect was no longer statistically significant. So this is a busy slide. Ketamine is being increasingly used and investigated for headaches. These are some of the studies that have looked at these. They've given ketamine intravenously, subcutaneously, intranasally for migraine and other headache disorders. The headache disorders are also considered like a continuum, where you have some that are really classically nociplastic pain, like migraines, and some that might involve more peripheral mechanisms like tension headaches. And so what you can see is that, ketamine is effective for, acute headaches. As you go further out in time from the time it's administered, so after, let's say 1 hour, certainly at 2 hours, ketamine is probably not better than other treatments like nonsteroidal anti-inflammatory drugs. Ketamine may have a beneficial effect on aura in patients with migraine. And there is one study that shows that it could have some preventive effects on migraine in some patients. So this kind of summarizes our meta-analysis to some degree. If you look at the effective dose, almost all studies, all guidelines, all reviews show that there's dose responsiveness. Higher doses are better. So when we use the receiver's operating characteristic curve or ROC curve to try to find the dose that best separated positive studies from negative studies, it was 400. Of course, you have to consider that, 400 milligrams given over 2 or 3 hours is going to be much different than 400 milligrams given over a week as an outpatient. It's probably not just dose, but the peak blood levels and the rate of rise to peak blood levels, i.e. the euphoric or psychedelic effects that determine effectiveness. So the mean reduction for high dose was minus 2.72 points versus 1.2 points for the lower dose. When we looked at differences between standalone versus add-on therapy, there's no difference. We thought that ketamine might work better for neuropathic or even nociplastic pain because the NMDA receptor is involved in central sensitization, and most animal studies, the large majority, have examined ketamine for neuropathic pain, but we couldn't demonstrate that it worked better for one type of pain condition than another. So going back to dose response, right? All analgesic medications are associated with a therapeutic range. You can see this range in, FDA monographs. For depression, a review published about 7 years ago in JAMA Psychiatry found that doses above 0.5 milligrams per kilogram over 40 minutes were more effective than lower doses. There's lots of reviews that found the same thing, one by Dermot Mayer, one by Knoppers, where they used the duration of infusion as a surrogate to dose. You can see this in the results of our trials. There's other indirect evidence. There's an observational study by Kiefer where they were giving anesthetic doses, so 7 milligrams per kilogram per hour or higher, And that's because they found that higher doses work better. And as I mentioned before, Schwartzman stopped their 2009 randomized controlled trial so that they could give higher doses. So ketamine is often thought to work because it could reverse central sensitization, because central sensitization is mediated to a very large extent by the NMDA receptor. So condition modulation is kind of a surrogate marker for, descending pain inhibition. So to give an example, you could measure pain threshold and pain tolerance in people, and you would find, certain levels. Then if you did something painful to them, you dip their hand in ice water, or you put something on their ear so that it squeezed their ear with pressure. And then you recheck those pain thresholds and pain tolerance, you would find that people have higher thresholds and tolerance. But it's very difficult to see this. So in a study by, Neisters, a crossover trial in 10 patients with neuropathy that compared ketamine to morphine and placebo, ketamine caused greater decreases in pain than morphine, but there were no differences in conditioned pain modulation. The study to the right here by Nickel is interesting because they took 48 volunteers. They underwent conditioning noxious electrical stimulation for 5 days and at day 22. And in 36 of them, they were subject to general anesthesia with different, anesthetics. So these were propofol, and remifentanil. Remifentanil is really the prototype opioid, so ultra short acting, that elicits opioid hyperalgesia, a form of central sensitization. And then there was a group that got propofol, remifentanil, and ketamine. It was double blind. They also had a control group that didn't receive anesthesia. And what you can see here from the graphs is that the propofol remifentanil showed a strong trend towards more secondary hyperalgesia at day 2 than the other groups. However, when ketamine was added, so propofol, remifentanil, and ketamine, it protected against this hyperalgesia. This is a busy slide. I'm going to try to summarize it pretty quickly. There's been lots of studies that have evaluated the effects of ketamine on quantitative sensory testing. Now, quantitative sensory testing can also suggest central sensitization, looking at things such as I mentioned, conditioned pain modulation or temporal summation. So in normal people, if you keep applying the same noxious stimuli, it decreases. They become habituated to it. But in people with central sensitization, it actually can become amplified. So if you look at these studies, and they've looked at, ketamine, the effect of ketamine on quantitative sensory testing in a whole bunch of different conditions: phantom limb pain, post-traumatic neuropathy, spinal cord injury, intraoral pain, which is a model for acute pain, complex regional pain syndrome. You just do not see, any effect on quantitative sensory testing. So any elevation of pain thresholds or increase in pain tolerance for ketamine after ketamine is out of your system. But ketamine is acutely more effective than other medications like lidocaine and calcitonin in reducing pain. Not surprising, ketamine is an anesthetic agent. So what other evidence do we have that ketamine can or cannot reverse central sensitization? So neuroinflammation is implicated in chronic pain, neurodegenerative disorders like Parkinson's disease, stroke, multiple sclerosis, cognitive impairment, and nociplastic pain conditions. It involves the activation of NMDA receptors, and it could be prevented by NMDA receptor antagonism, which inhibits microglial activation and decreases the levels of pro-inflammatory cytokines. So Stubhog took 20 living kidney donors. He randomized them to receive 0.5 milligrams per kilogram ketamine bolus before incision followed by a 48-hour infusion, or saline. And the ketamine group had decreased areas of punctate hyperalgesia and temporal summation, again, indicative of central sensitization. So this is the 800-pound gorilla in the room, really for all clinical trials, but probably more importantly for ketamine. The placebo effect is enormous for chronic pain. It's indubitably, so indisputably, the placebo effect is stronger than the intrinsic effect for almost all pain treatments, pharmacological ones, integrative ones, surgical therapies, and non-surgical procedure interventions. And there's lots of things that affect the placebo response, patient-doctor relationships, expectations of both the patient and the doctor, obvious treatment effects, which is really important for ketamine. Procedures have stronger placebo effects than pills. That's shown in multiple meta-analyses, site factors. It's a misconception that, pain relief that lasts a long period of time, can't be from the placebo effect. This totally depends on expectations. So effects of placebo, just like all treatments, decrease with time, but expectation bias can increase with time. So we did a study, we did two studies. One was to determine how pain or how temperature increase after a sympathetic block correlated with pain decrease after the block. And then we looked at the patients who underwent ketamine infusions for CRPS and how that correlated with sympathetic blocks. This was done at 4 institutions. And we found there was a weak correlation between temperature increase and response to ketamine. But there was a stronger correlation between temperature increase and pain decrease after sympathetic blocks, such that in multivariable analysis, it was no longer statistically significant. So 61% of those with sympathetically maintained pain, defined as those who had 50% or greater reduction right after the block, versus 27% of those who had sympathetically independent pain responded to ketamine. In multivariable analysis, the only things that were associated with response to ketamine were sympathetically maintained pain, i.e., those who had more than 50% pain, 50% or more pain relief right after the block, and obesity. And the obesity thing is very interesting. We're doing an invited review for BMJ Medicine now on outcome predictors for chronic pain. And being overweight predicts failure for almost every treatment. So it was very unusual that obesity would be associated with a positive outcome. We also measured, sought to see if people were depressed or they had any other psychiatric condition, and they were not associated with outcomes from sympathetic blocks. But we didn't actually measure depression or anxiety. So this is a kind of a summary of all of the literature. So what's associated with ketamine outcomes? Well, improvement in pain thresholds, not surprising. Having a strong affective component to pain. And I showed you the quantitative sensory testing slides, and as you could see, right, after 48 hours or later, ketamine does not affect pain thresholds or pain tolerance, but some people feel better. Why? Feeling less pain or becoming more tolerant to pain. I think it's because it works on this affective component of pain. And there are not one study, but there's another study that was never published in peer-reviewed literature, but it's presented, that also found that obese patients responded better to ketamine. And when looking in the literature, what you can see is that obese patients have higher affective components, which could explain it. There are some studies that find that, males, people who are younger age, respond better in those with sickle cell vaso-occlusive crisis One study found that back or abdominal pain responded better to chest pain, and as I mentioned before, longer duration and higher dose. So our group did a series of studies looking at IV ketamine tests to predict oral NMDA receptor antagonist response, specifically dextromethorphan. This was at a time where people were using IV infusion tests like lidocaine before maxillatine or opioid tests to predict long-term response to opioid. We used extremely low doses, 0.1 milligram per kilogram of ketamine, and then we put people on dextromethorphan high doses. So a milligram per kilogram given 3 times a day, sometimes higher, sometimes lower. The ketamine infusions were blinded and there was a control. So they got saline, they got midazolam, they got ketamine. They didn't know when they got ketamine. And as you could see from the second to bottom line, this had, pretty high sensitivity, specificity, positive and negative predictive value. The negative predictive value was very high. And IV midazolam, not surprisingly, right, placebo, it predicted a response to ketamine, but it didn't predict response to dextromethorphan. So what about oral NMDA receptor antagonists? Well, the results are mostly negative for oral ketamine. Ketamine has low bioavailability, very limiting because people can't work, people can't drive. There are several randomized controlled trials that demonstrate efficacy for short-term benefit for intranasal ketamine that has rapid onset, rapid offset, and a pretty high bioavailability. When you look at the effects of like oral memantine for post-herpetic neuralgia, for post-amputation pain, they're negative. Memantine and dextromethorphan can have preventive analgesic effects, like when given before surgery. So this is a oral NMDA receptor antagonist. For dextromethorphan, the results are mixed. There's 3 negative trials and 2 small positive trials, both done in post-amputation pain. For amantadine, again, mixed results, 2 positive trials in neuropathic cancer pain and diabetic neuropathy, 1 negative in lumbar radiculopathy. Memantine results are negative. Magnesium, 2 small positive studies, and other novel glutamate antagonists negative. So a huge amount of literature for pain is in the emergency department literature. This is a systematic review by Carlo, published in 2018 in Annals of Emergency Medicine. It was a meta-analysis comparing low-dose ketamine to opioids for acute pain in the ED. The primary outcome was pain closest to 10 minutes after administration. They had 3 studies, 251 patients. The mean difference in pain scores was greater for ketamine by 0.42, but ketamine also required more repeat doses and was associated with more adverse events, 18 versus 8, and they concluded that ketamine was not inferior to opioids. This is a meta-analysis of placebo-controlled trials for postoperative pain in opioid-tolerant patients. So this is a really ideal group that would receive ketamine. This meta-analysis included 9 studies with 802 patients. There was a lot of heterogeneity. 3 studies started the infusion before induction, after induction in 2 patients, and in the PACU in 4 patients, and they continued it for at least 24 hours in 2/3 of the study. And they found small reductions in pain with movement and at rest favoring ketamine, but they found that ketamine was associated with a very large decrease in opioid consumption through 48 hours. But these studies almost all had a high risk of bias. Sickle cell anemia, again, this is a really good population to study ketamine. They're young, they're often opioid tolerant, they're at high risk for opioid-induced hyperalgesia because of their age. There's a couple of studies here. Study by Lubega, published in 2018, was a non-inferiority study in 240 children with vaso-occlusive crisis. They compared 0.1 milligrams per kilogram of ketamine to 1 milligram of ketamine over 10 minutes. So pretty big dose. And the maximum reduction in pain was comparable for the two treatments. Ketamine, again, had a faster onset, but shorter duration and was associated with more effects. So very similar to the meta-analysis for acute pain in the ED. Morphine was associated with more treatment failures. In a subsequent randomized trial, that compared morphine to ketamine, they used much lower doses of ketamine in 278 adults with vaso-occlusive crisis. Al-Shahrani found that there was no difference in pain scores through 3 hours or admission rates, but ketamine, not surprisingly, because they didn't get opioids, they had less opioid consumption, but again, more adverse effects in ketamine patients. Can ketamine reduce the incidence of persistent post-surgical pain? So a systematic review of 17 studies, over 750 patients by McNichol that looked at epidural and IV ketamine failed to demonstrate a significant reduction in the risk of persistent post-surgical pain. It was 28% incidence in ketamine versus 35% in the placebo group. This 16% reduction translated to a p-value of 0.06 at 3 months. Epidural ketamine for the interventional pain specialists and the anesthesiologists who are listening to this talk is probably associated with neurotoxicity in high doses. So when they looked at only the IV studies, they found that the effect was very weak. So you needed to treat 12 people to prevent persistent post-surgical pain at 3 months with ketamine, and the NNT increased to 14 at 6 months. Another systematic review by Klatt found a small preemptive effect at 1 month, but not afterwards. Only 3 out of 10 studies were positive. And if you look at 4 randomized controlled trials published after these reviews, they're all negative or at best equivocal. These are summaries of our 2018 guidelines on the use of ketamine for acute and chronic pain. I'm just going to highlight, these were published in Regional Anesthesia Pain Medicine, some of the differences between acute and chronic pain. So for chronic pain, higher doses we recommended, so up to 2 milligrams per kilogram per hour. And when you get above 1 milligram per kilogram per hour, there has to be extra monitoring versus 1 milligram per kilogram per hour for acute pain. And the reason is, as I pointed out, higher doses are believed to be necessary for the relief of chronic pain and possible reversal of central sensitization. The other main difference in these guidelines for acute and chronic pain are the contraindications. So because it's imperative to treat pain after acute trauma, be it surgical trauma or polytrauma, we did not list active substance abuse as a contraindication, whereas active substance abuse is listed as a contraindication for chronic pain guidelines because there is a growing population of people with ketamine use disorder. These are the guidelines, again, published in 2018 in Regional Anesthesia and Pain Medicine. I'm going to switch gears now to psychiatric comorbidity. So the co-prevalence rate of depression in people with chronic pain is very high, between 30 and to over 60%, probably somewhere around 50-something%. Ketamine makes people feel good. That's why it's abused. Low-dose ketamine alleviates depression. To summarize this, IV ketamine seems to work better than intranasal ketamine. Higher doses are more effective than lower doses, and racemic ketamine works better than S-ketamine. There's growing evidence for PTSD and other psychiatric conditions such as anxiety disorder, but as I mentioned, there's also a growing rate of abuse, and people with psychiatric conditions are at higher risk for abuse. When I went to present on ketamine before the June 2024 FDA panel, at DuPont Circle in Washington, D.C., someone presented on the rate of abuse, and they cited a study that showed like high teens in New York City club goers. So more than 15% of people within the past month who were, polled at New York City nightclubs had reported using ketamine. And there's one study that found that ketamine was extremely common in non-fatal motor vehicle collisions when they tested for it. So ketamine is not unique in being effective for depression. Almost everything that can treat depression can also treat pain. So these include, SNRIs like duloxetine, tricyclic antidepressants like amitriptyline and nortriptyline, even higher doses of SSRIs, which at high doses become effectively serotonin norepinephrine reuptake inhibitors. ECT can work. Older antidepressants like MAO inhibitors, direct cranial stimulation and repetitive transcranial magnetic stimulation can work. And the mechanism for psychiatric conditions may not just involve NMDA receptors, but can involve the upregulation of non-NMDA glutamate receptors, AMPA, and metabotropic glutamate receptors. Also probably involves activation of brain-derived neurotrophic factor, mTOR or mTORC1, and the metabolites norketamine and hydroxynorketamine. All of these are potential targets. Without going into this, there's more literature for psychiatric indications than there is for pain. Again, to summarize the results of studies for depression, IV ketamine seems to be more effective than intranasal treatment, but only intranasal treatment is approved. There's a dose response. Multiple treatments work better than single treatments. Racemic ketamine works better than S-ketamine when given IV, and that's a very significant effect. Look at the risk ratios there. There seems to be a correlation with psychomimetic effects, although most studies don't evaluate psychomimetic effects. Not surprising, right? Ketamine is a psychedelic drug. There's a lot of psychedelic therapies that are being investigated for psychiatric indications. Without repeat dosing, symptoms seem to return to baseline within 4 weeks, so it's not much different than with chronic pain. And based on questionnaires, suicide risk is also reduced. We have a very large DoD grant, as I mentioned, looking at ketamine for PTSD and TBI-associated headache. When we put together this grant many years ago, there was only one randomized trial. Now there's many, but most of these are not double-blinded. About half use active controls, usually midazolam or ketorolac. And a big problem is that most of these studies also provide psychotherapy, which can confound results. Ketamine seems to be more effective for treating chronic PTSD than acute PTSD, which is very different than pain. Acute pain responds to treatment much better than chronic pain. And in fact, there's some suggestion that it can worsen PTSD symptoms in some patients. The doses are similar to those used to treat depression, 0.5 milligrams per kilogram IV over 40 minutes. One study compared that dose to a lower dose, 0.2 milligrams per kilogram. They found no difference in response. Both were negative. And in one interesting study that also used 0.5 milligrams per kilogram of ketamine and compared it to midazolam accompanied by exposure-based psychotherapy for 4 days, they didn't find a difference in PTSD symptoms between groups, but they found that ketamine reduced memory, induced amygdala and hippocampus activation on fMRI through 30 days. So the surrogate outcome measure was positive, and this is very important. The FDA considers this important. If you look at drugs that they approved recently for conditions like Alzheimer's and similar, the effects last about 3 weeks or less after the final treatment. What about anxiety disorders? So anxiety disorders associated with glutamate receptor malfunction in the hippocampus and atrophy in the prefrontal cortex. DA receptor antagonism on GABA interneurons can increase extracellular glutamate and activate AMPA receptors, can also increase signaling of BDNF, brain-derived neurotrophic factor, and mammalian target of rapamycin complex 1, so mTORC1. In a systematic review by Tully and colleagues, evaluating 8 studies on refractory anxiety and 10 on treatment-resistant depression accompanied by refractory anxiety. They included 4 trials for anxiety, 2 were placebo, 2 included psychoactive control groups, and 3 studies for depression with anxiety, 2 were placebo-controlled. Almost all studies demonstrated anxiolytic effects that far outlasted the duration of effect for ketamine. Again, the findings are that higher doses are more effective. Social anxieties may respond better than general anxiety disorder. That may be a reflection of greater disease burden with the latter. What about other psychiatric conditions? Well, a small randomized trial compared ketamine 0.5 milligrams per kilogram IV to midazolam. It showed improvement in borderline personality disorder in some metrics. So suicidality was reduced, depression was improved, as well as socio-occupational functioning, but not on borderline personality disorder symptoms through 4 weeks. In a clinical study evaluating 100 patients with refractory depression who had comorbid bipolar disorder, both groups showed equivalent improvement in depression. In another small placebo-controlled trial for OCD, authors found benefit for the same dose of ketamine, 0.5 milligrams per kilogram IV. And this is also supported by preclinical studies. OCD is really a form of anxiety disorder. For alcohol use disorder, 2 randomized trials found ketamine plus psychotherapy was more effective than psychotherapy alone for abstinence, but not for relapse. And there's extensive literature suggesting that ketamine and other NMDA receptor antagonists can mitigate opioid withdrawal symptoms. I think we published a case report in somebody on tens of thousands of oral morphine equivalents a day through an intrathecal pump who had the catheter cut. We put them on ketamine in ICU, and it mitigated withdrawal symptoms. And by the time the person was discharged, they were just on small doses of oral oxycodone with no worsening of pain. Neuropathic itch. So itch is often considered a variant of pain, right? You can get itch after burn injuries, with scars, with animal and bug bites. It's transmitted, through similar tracks, through like the spinal thalamic tract, transmitted by C and A delta fibers that don't respond to mechanical stimulation, and you have the same neurotransmitters and neuropeptides involved: CGRP, glutamate, substance P. Itch can be localized or it could be diffuse. The dermatology community calls this neuropathic itch. We would call this nociplastic itch, right? Because there's no identifiable nerve injury. Neuropathic itch or nociplastic itch, whichever you want to call it, involves peripheral and central sensitization, again, with the same inflammatory mediators. And lots of the treatments for neuropathic itch are the same as they are for neuropathic pain: gabapentinoids, antidepressants, capsaicin, local anesthetic blocks, clonidine, and itch can be worse by stress and can be sympathetically maintained pain. So we published a really interesting report on somebody who had completely debilitating total body itch. She responded to ketamine and lidocaine infusions. We did field blocks, and the field blocks relieved some pain, suggesting some peripheral mechanisms, but even areas that were not subjected to the field blocks, they also decreased itch. So there are peripheral and central mechanisms. We actually measured cytokine levels, they would decrease. The decrease lasted for a long time after the infusions, as you can see here by the graphs. There's some other studies. There's a placebo-controlled trial in which 100 patients with trichotillomania or skin pricking disorder or both, were randomized to receive placebo or memantine, an oral NMDA receptor antagonist, for 8 weeks. These conditions are characterized by, glutamatergic dysfunction and OCD-like behaviors or obsessive compulsive behaviors. They're accompanied by significant at the end of treatment, there were improvements noted on all measures. 60.5% of people who received memantine were much improved versus 8.3% in the placebo group. So this is a very, very large treatment effect. So what are the contraindications for ketamine infusions? Well, side effects from ketamine are related to peak blood levels and probably rate of rise to peak blood levels. So they're not different than like side effects from antibiotics. We listed active substance abuse as a contraindication for chronic pain. That's because ketamine infusions for chronic pain are elective. That's not the case for acute pain, where the failure to treat acute pain can have significant long-term consequences. The reason we did this is because, ketamine is a controlled substance. People can develop ketamine use disorder, especially people with other substance use disorders. And that's why, psychiatrists, rehabilitation centers, they don't just test for drugs of abuse, but they test for, other alternative substances. So if you're abusing opioids, you can't drink, you can't take other controlled substances. We listed intracranial pressure and intraocular pressure, elevated intracranial and intraocular pressure as, relative contraindications. So the evidence for that goes back decades, but it's with anesthetic doses and it's quite weak. Ketamine can cause hepatotoxic and urogenital effects, so systemic inflammation of the bladder and other parts of the urogenital system. It can cause hepatitis, an increase in liver function tests. The urogenital effects may also possibly be related or increased with adulterants. Psychomimetic effects are quite common. So systematic reviews of studies find less than 10%, but most of these studies gave preemptive medications to prevent it. If you don't give them, it's actually very high. So we found a greater than 50% incidence in our studies when only 0.1 milligram per kilogram was given. In a retrospective study by Eric Schwank and colleagues in Pennsylvania, they found that there was no association between the infusion rate and discontinuation. In other words, side effects can happen at any dose. The American Psychiatric Association suggests there are a few psychiatric contraindications for treatment of depression with ketamine. In fact, the psychiatric indications for ketamine treatment are expanding. So there are anecdotal reports that ketamine can provoke psychotic symptoms, but a recent systematic review of 9 articles suggests that ketamine can be used in patients with a history of psychosis, even those who have active current symptoms. And as I mentioned before, ketamine, when given neuraxially, can be neurotoxic. So these are the take-home points for pain. There's evidence for short-term efficacy based on clinical trials, but the benefits diminish over weeks, and these studies are inherently flawed. Specifically, they have small numbers, and blinding is probably not effective. Ketamine seems to have a greater effect on the affective motivational component of pain than sensory discriminative component. This is based on QST studies that show after 48 hours, there's just no increase in pain threshold or tolerance, but some people still feel better. It's not clear whether ketamine can reverse central sensitization. There's mixed evidence for oral NMDA receptor antagonists for pain, and there's some evidence that low-dose IV ketamine can predict who will respond to oral NMDA receptor antagonists, specifically dextromethorphan. And ketamine infusions can be useful in patients with an active substance use disorder for acute traumatic pain, but they're contraindicated for chronic pain in this context. For psychiatric disorders, there's growing evidence of efficacy for a variety of psychiatric disorders characterized by mood and anxiety, including PTSD. There's also some evidence for personality disorders. Racemic ketamine, given intravenously in high doses, may be more effective than intranasal S-ketamine. But IV ketamine is not approved for any psychiatric or chronic pain disorder. And the effects, wane, recurrences occur, necessitating the need for repeat infusions. Thank you.